In today's video, we're going over what physical therapists need to know about patellofemoral pain. What's going on? This is Dan Pope and Kevin Coughlin. We are physical therapists. We operate out of Champion PT and Performance. We are here gathering the data, doing experiments on our patients, making them better, sometimes hurting them, making those mistakes so you don't have to. How are you doing today, Kevin?
I'm doing well, Dan. I'm happy and excited to make this transition from the upper extremity to the lower extremity. So kind of diving into the knee here, and I'm excited to kick things off. How about you?
Yes, I am. I've always been a kneecap guy, and I'm pumped about this one. It's little history. I've been doing these kind of deep dives into certain pathologies with patellofemoral pain being one of the big ones. And I did my first deep dive, I want to say around 2015, 2016. And then I did it again when I did my knee course. And then I did it again a couple years later. And now this will be my next. So it's kind of cool to go back in the literature, see if anything has changed, try to think if I've changed what I do from a treatment perspective. Is there anything that's kind of on the way out or the way in, and just updating my thoughts and seeing if there's anything cool popping up in that literature, like I was saying. So I'm pumped, man. So pumped.
Awesome. Yeah, when I think of you, I think of the patellofemoral joint.
Yeah, some people call me patella.
That's
not true. Sorry.
All right. Well, let's
rolling.
kick it off here. So we're going to get into the episode, what PTs need to know about patellofemoral pain. So just starting with a little bit of background and a definition. So patellofemoral pain, I think aptly named, is pain around or behind the patella, so the kneecap, which is aggravated by at least one activity that loads the patellofemoral joint. So this could be squatting, this could be stairs, jogging, running, hopping, jumping, anything that's loading the joint. So, when someone comes in with knee pain, in order to give someone this diagnosis, you want to make sure there's at least one aggravating factor that's loading the patellofemoral joint. And we'll get into kind of how the biomechanics work there, but that's just a little background to orient yourself for what we're about to talk about.
Yeah, good stuff. And I don't want to give too much away because I know you're going to cover it, but yeah, it truly is pain kind of behind that kneecap, aggravated by those activities. And you're going to pick that up, obviously, in the subjective portion, but that's actually really important information to know. And later on, we'll talk about how you are a little bit more specific about maybe differential diagnosis, because we know this is a diagnosis of exclusion. So those are important little tidbits. My patients keep telling me that they have pain right behind the kneecap. Hurts when they squat, hurts down the stairs. I think it's patellofemoral pain. What the hell does the research say about patellofemoral pain? PubMed.com. All right, there we go. Okay, excellent. There's 335,000 studies to read. Gosh, too much. I'm getting frustrated. Whoa, calm down. No need to be frustrated. This is Dan Pope. I have fabricated what I believe is the perfect solution to your problem. It is the patellofemoral pain evidence-based cheat sheet. And I'll catch you up to date on patellofemoral pain under 10 minutes. Well, I'll tell you what, Dan, that's actually pretty helpful because I'm kind of dumb and I don't like to read. Well, don't you worry. I'm dumb too. But when it comes to patellofemoral pain, I am not. We're going to go over all the greatest hits: definition, anatomy. What the heck is the pain generator? Are there any risk factors for this condition? What's the prevalence and clinical presentation? How about mechanisms of injury, differential diagnosis, how you even go about diagnosing this? And then our favorite, evidence-based treatment. So that's my promise. I'm going to get you up to date on patellofemoral pain under 10 minutes. I'll leave a link below in the show notes in the description. Go ahead and click on that link and get to learning.
Awesome. So getting into a little bit about the biomechanics of the patellofemoral joint. So when the knee flexes, the patella glides inferiorly. When the knee extends, it glides superiorly. So there is obviously a little bit of joint play that you'll find medial and lateral, but we primarily think of this as it will be equated to the train track sitting in the groove, right? Sitting in the track, the train in the track. So you'll hear that often kind of when you hear people talk about patellofemoral pain. So the kneecap has a little bit of movement in that patellofemoral joint as you're bending and straightening your knee. And then in terms of the joint contact surfaces, because this does change as the knee bends and extends. So initial contact between the posterior part of the patella and the femur, the track it sits in, starts around 30 degrees of knee flexion. So when you're standing and your knee is extended, you don't have much contact between the back of the patella and the joint there. Um, and then the joint surface contact increases gradually between up until 90 to 120 degrees. So at that 30-degree flexion mark, you have some joint contact. And then the more and more you flex up until, if you're picturing a squat, say you're parallel or a little past parallel, you start getting maximal joint contact. And that makes sense because when you're talking with someone about what might hurt and they say, squatting hurts, but if I partial range, it's a little bit better. I kind of go deeper there and it's really, really painful. That that definitely checks out. That makes sense. We know you have more joint contact there. Um, and then there is a role of the quadriceps, right? So the deeper the knee flexion, we're probably getting some more compression at the patellofemoral joint as well. And we'll talk about the quad's role with muscle contraction because that's going to affect the biomechanics at the patellofemoral joint and contribute to some of these compressive forces. But that's just a little bit of background on the joint surfaces.
Cool. Good job, Kevin. I like that part.
Thanks, dude.
One thing I will say, and I don't think this has been parsed out too well in our medical literature, I'd like to see more of it. And the reason why this is interesting to me is because I work with a lot of Olympic weightlifters and CrossFitters, and obviously they're squatting as deep as they possibly can, right? The knee pain is very prevalent with those folks. It's usually one of the top three most injured areas, patellofemoral pain being the big one. You'll actually see some small, poorly controlled studies that show that Olympic weightlifters at international level have more patellofemoral arthritis by a good margin than regular sedentary folks, which a lot of that may be a problem with, it's a small study, wasn't really controlled well for things like body weight, body fat, so on and so forth. But that is a little alarming to me because we want these athletes to stay healthy long term. We know squatting deep does put a lot of stress on the patellofemoral joint. So I'm usually a gray guy. I'm not the person that says squatting is bad. I'm not going to say that squatting is like never going to cause any problems, right? I'm somewhere in between the two. How can we make squatting safer? As you descend into a bottom squat, obviously more and more stress on the patellofemoral joint. One thing you will find in our literature as well is there's something called a wrapping effect. It just means that when you get to the very bottom of the squat, the quad tendon actually is now within the joint, and that helps to dissipate some of those forces. So the contact area does decrease within the joint, right? So kind of the joint surfaces with the bone, the cartilage. But then the quad tendon actually ends up making an appearance, which may or may not be involved with quad tendinopathy, which we'll talk about at a later date, right? So that does happen. And the last piece at the very bottom of the squat is that your hamstring does bump up against the calf. Some folks kind of theorize that that also decreases some of the forces in the patellofemoral joint because now you have those passive structures kind of bump against one another. Anecdotally, I think most people do hurt as they descend deeper and deeper into the squat. They hit that hole. Sometimes they feel better in the very bottom, and then they start descending out of the hole. They're like, it feels like garbage. They get through a sticking point, and then it feels a little bit better. So I think that what you said is kind of spot on there, Kevin. Besides that very bottom part of the squat, which hasn't been studied especially well. So
Yeah. I just had a quick question. When you said that there seems to be a certain percentage of like Olympic weightlifters or power lifters with arthritis of the patellofemoral joint, um, do you know if they're clinically symptomatic, or do you know is that just findings that the joint is a little bit more degenerative? Do you recall at all?
I want to say symptomatic. That's always the next question, which I think is good because people are like, oh, well, arthritis doesn't matter. There's no correlation with pain. But in a lot of these studies, they'll actually term severe osteoarthritis as folks that are at least eligible or have gone through with a knee replacement surgery. So their definition of arthritis is, probably spot on for people that are really hurting, right? As opposed to like, I don't know, if you have quite a bit of cartilage loss and you might not even know you have arthritis, right? And they take an image and like, well, it looks like you do have arthritis, but you had no idea what's going on. But I'd have to go back and read through that literature. Maybe I will leave a link in the show notes for folks to read. I went pretty in depth on this in my knee course because I really wanted to get some of those answers. It's like, is squatting actually bad for us? Because I work with a bunch of guys that are just hammering Olympic lifts all the time, right? And they may operate on this pretense of like squatting is always good for you. Well, in these extreme situations, sometimes, maybe not. Maybe not. I just say maybe because we don't know, but that's what the poor research we have is pointing to.
Awesome. So just continuing on the biomechanics of the patellofemoral joint. So the more joint contact surface is better at dissipating stress. So, when you are in that, 90 to 120 degrees of a squat, you have more contact surfaces with the joint, which doesn't necessarily mean it's going to cause pain. You actually want that because the more contact between the two joints, it's better at dissipating stress than when there's just a little bit of joint contact. But the more, when you're in that deeper squat position, you are getting more recruitment of your quadricep. And that also is going to increase stress through the patellofemoral joint. So, from a performance standpoint, it makes sense that when the joint is dissipating those forces, you're able to lift more weight. But, if you do have an aggravated patellofemoral joint, it might come at a cost there. And then just to give you some idea about how much load is going through the patellofemoral joint with common exercises or activities we see with our patients. So this study was looking at that, and they were looking at as a percentage of body weight. So 1.3 times body weight is going through the patellofemoral joint, just walking on a level surface. So you're getting more than 1 times body weight there. 3.3 times body weight with stair negotiation, 5 to 6 times body weight with running. And so we didn't say this yet, but patellofemoral pain is also called runner's knee. So common injury in runners for sure. Probably one of the top ones. And then 7 to 8 times body weight during a deep squat. So, some pretty significant forces going through the joint there. And then we do have to always consider what's happening in the kinetic chain. So the way that some of our other joints move, your hip, your ankle, your foot, plays a role in stresses through the patellofemoral joint. And just one example I'll throw out there, just thinking about, weightlifting, is if you have a lifter with kind of poor ankle dorsiflexion and they're trying to get down into their squat, that extra motion has to come from somewhere. And they may be picking up more motion through their patellofemoral joint or through their hip as well. So, or, likewise, someone with poor hip mobility or hip pain with squatting, they may recruit more knee flexion, and then maybe we see more stress going through the knee with that. So those are joints we want to look at and see if it's something we could address in rehab. And then also just thinking about the active and passive structures around the knee. So, there are a lot of passive structures. You have your medial patellofemoral ligament. You have some lateral support there as well. And then obviously the role of the quadriceps, the role of the calf, the hamstring. So just looking at the big picture as well with these patients.
Yeah, for sure. And you already mentioned this, but you'll get into this, I'm sure, a little bit later. But we still don't really know exactly what creates pain in folks that have patellofemoral pain. Ends up being this diagnosis of exclusion. Maybe later on we'll figure out there are specific structures, and maybe there's different structures. So patellofemoral pain does a bad job of classifying which structures are aggravated. There is a thought that some of those medial ligaments might become painful too. But the thought is that those passive structures help to stabilize the joint. And then maybe those passive stabilizers sometimes get aggravated too. But that's kind of yet to be seen.
All right. So getting into a little bit about who gets patellofemoral pain, like what types of patients are we seeing? How frequent are we going to be seeing it? So I thought this statistic was crazy. It said between 1.5 to 7.3% of all patients seeking medical care are seeking it for patellofemoral pain. So you think about our whole medical system and all the different things we see people for, and that's a pretty staggeringly high number. So this is a common thing. This is something you're definitely going to see. About 25% of all of the cases in an orthopedic setting may be surrounding patellofemoral pain. So that's about 1 in 4, that's wild.
That is crazy.
Yeah. 1040, Dr. 1040, he's out of Boston, showed that a lifetime prevalence of patellofemoral pain in high school runners is 21% for females and 17% for males. So again, runner's knee, and that's about 1/5 of all runners dealing with this at some point. Um, Generally, we see this condition being more common in females versus males. It affects people across the lifespan. It kind of seems to depend on the study population, but we do see a lot of times that the numbers might be higher in younger athletes. So kids that are more active and maybe going through a period of rapid growth. Um, we could wonder why. I wonder if it's just that the younger population is just generally more active, right? So they're doing more things that are putting load through the patellofemoral joint. But there does seem to be some correlation with the periods of rapid growth as well. So, yeah, a little bit of background there on prevalence.
Yeah, and like Kevin said, it's just extremely, extremely common. And one thing, and this is lecture for another day, but I also see this somewhat continuous with patellofemoral arthritis. Because you're getting patellofemoral pain doesn't mean that you are developing arthritis. I'm definitely not trying to give that thought. But if you have a patient that comes in that has that anterior knee pain and they're, let's say, 50 plus years old, I start to think this might be some arthritis as well. So just make sure that's on your radar with your differential diagnosis. Not to say that folks with osteoarthritis can't get better with exercise and other treatments, but just something to think about some.
Just continuing with who gets patellofemoral pain, I thought these quotes were pretty interesting because a lot of times you'll see or hear physical therapists blaming patellofemoral pain on certain aspects about the patient or certain biomechanics that they display, and we're just not exactly sure what is the cause or the source of pain. Like Dan was saying, I think we're still trying to figure this out. But a recent systematic review of observational studies concluded that age, body mass, height, body mass index were not risk factors for the development of patellofemoral pain. Specific to the lower extremity structure, the quadriceps angle, also known as the Q angle, um, assessed either in weight bearing or non weight bearing, was not a risk factor for the development of patellofemoral pain. And I think this is something that's just been changing a little bit over time because I remember in school learning that, we measured Q angles on people and that was something that we might see, especially in the female population, that makes them more susceptible to developing patellofemoral pain. But at this point, we're still not sure. It doesn't seem like that is a causative risk factor. And then this other quote, patellofemoral pain is often believed to be related to excessive foot pronation. Overall, excessive foot pronation does not appear to be a feature across studies examining individuals with patellofemoral pain. So again, the consideration when you see someone who has patellofemoral pain in the clinic and they have excessive foot pronation, I think we want to be careful with how we word that to them, that this is something that is causative and now we have to fix it. We always want to just be careful in how we word things. I think when we talk about a future podcast that we're going to be doing on the treatment for patellofemoral pain, does get a little bit confusing because some things like certain foot orthoses may be helpful in improving pain, but we still don't know for sure that this is the causative of pain. So I think it's important to tease that out so we can kind of word this the correct way to our patients and not make them, worry about things that they probably don't need to worry about.
I know you're going to be talking about this a little bit in the next few slides, but I think what Kevin's getting at, and most people already know, is that dynamic knee valgus is like the boogeyman, right? We used to think that causes all of our problems, and that's still very much in the air, up in the air, excuse me, and up for debate. We're not really sure how much dynamic knee valgus is contributing to folks who have patellofemoral pain. I'm going to talk a little bit about in the treatment section, so I'm not going to go too crazy. But the thought is, if you're having dynamic knee valgus, so the knee is coming in when you're doing a squat, it lateralizes force on the patella, decreases surface area to dissipate force, right? And essentially, if I can get my knee lined up with my toe, and you can do that via trying to change foot posture. So if you have really flat foot, that's going to promote more valgus. If we don't have great control coming from the hip or we're having pain at the knee, this can all create valgus. But it's very murky, right? So it's not clear cut. So if you're the type of person that's like, oh, knees coming in, that's why you have pain, it's probably not true. There's probably a variety of factors, and it's not black and white whatsoever, which makes things a little bit more confusing, but that's the nature of it. Stinks, but we don't have all the answers.
Hey friend, if you're liking this content, I have something I think that you're really going to love. And that would be a master course on rotator cuff related pain and rotator cuff tears. Having the patient come through the door and you don't know how to treat their pathology, that stinks. You feel like a fraud, you're just making stuff up, it's not good stuff. It's also pretty dang tough staying on top of all the literature that's coming out all the time. Well, guess what? I have done this for you by making a master course on rotator cuff related pain. Well, what kind of stuff do you go over in this course? I've got an evidence-based guide. We go over diagnosis and special tests, my favorite beginner, intermediate, and advanced exercises, how to modify your patient's training in the gym so they can keep on working towards their goals and not hurt themselves more, my favorite evidence-based manual therapy techniques for these folks, case studies on how to treat non-op and post-op patients, as well as the exact rotator cuff related pain protocol that I give to my patients when they come to see me with this common issue. Now that sounds pretty good, Dan, but how much does this cost? How does $1 sound? Whoa, $1? That sounds crazy. Why is it so cheap? It's mostly because I don't know how to run a business, but I do know about the rotator cuff, and I'll teach you all about that. This all comes with a subscription to Fitness Pain for Insiders. It's $1 for 1 week trial and $25 per month afterwards. However, you can cancel at any time. If you don't like it within the first 7 days, just tell me. I will cancel and refund for you. Plus, I have a lot of other really good courses in there as well. We have master courses for cervical radiculopathy, lumbar radicular pain, lateral ankle sprains, and what I'm working on next is, you guessed it, your favorite, shoulder instability. So click on that link in the description. It's $1. Go ahead and get started, and I'll see you on the inside.
Yeah, one last thing I'll say about that is I think I just want people to understand that going too far in either end of the spectrum there is probably not helpful, right? So if someone is demonstrating excessive knee valgus with certain things, and fixing that or modifying it helps the patient, then that's great. So we don't want to take the attitude that it doesn't matter at all, but we also don't want to, make people fearful about it. So I think it takes some nuance, and yeah, hopefully these just give you some things to think about. But further into diagnosis now. So how are we coming up with this diagnosis? I'll start with the bottom thing here because Dan has said it a couple times, but patellofemoral pain is a diagnosis of exclusion. So what that means is we have to rule out other diagnoses first. And I think the reason is that because we still don't exactly know what the pain producing structures are. So we have to clear a bunch of other things that we know it's not. And then we can feel better about the fact that it is maybe patellofemoral pain. But some other criteria that you want to think about, and I think this is from the clinical practice guidelines. So clinicians should make the diagnosis of patellofemoral pain using one of the following criteria. So they should have pain either behind the kneecap or around the kneecap that, they'll describe, and you can also palpate this, and you will see it painful in folks. There will be a reproduction of pain with something that loads the patellofemoral joint, such as squatting, stair climbing, prolonged sitting. I believe you could refer to that as moviegoer's knee. You might see that in the research. So you just picture, you're sitting in the movies for a long time. And I have memories of having this pain when I was in high school. Tons of knee pain with prolonged sitting, like would be in a school assembly. And like, why is my knee hurting so much? It's definitely dealing with some patellofemoral pain. So you might hear that from the person, or just other functional activities that are loading the patellofemoral joint. And then again, that third one, it's a diagnosis of exclusion. So we want to rule out other causes of anterior knee pain, which I listed some specifics in a slide in a little bit later. So we'll talk about what other things to think about. And then the clinical practice guidelines does try to subcategorize patellofemoral pain a little bit. So maybe you'll see someone who fits in the category of a more overuse or overloaded patellofemoral joint. So maybe this is someone who is, very active in sports, weightlifting, that type of thing. So it's primarily an overuse issue. We may see a muscle performance deficit. So someone who presents with quad and hip weakness, we could categorize them in that group. That movement coordination that we talked about. So maybe they have that dynamic knee valgus that increases their symptoms. And we find if we modify that, it's something that could make them feel better. and then mobility impairments. So, maybe the patellofemoral joint itself has kind of poor joint play after surgery, or they're just, older, maybe like Dan said, some signs of arthritis. We want to maybe work on their patellofemoral joint mobility, and also just assessing the quads and the hamstrings for what the mobility looks like there, the rest of the kinetic chain. So that might help a little bit with how you're thinking about what bucket this person's in. Maybe it could help guide treatment a little bit. But these are just some things to keep in mind when you're trying to diagnose patellofemoral pain.
All right. I think one of the big ones you already mentioned, this is a diagnosis of exclusion. So largely you're just trying to rule out other more serious pathologies, or other pathologies are just treated differently. And I think the big giveaway is where the patient's pain is, right? So I have that anterior knee pain that could be a couple different things. So in the front of the knee, you're thinking maybe quadriceps tendinopathy, or maybe some sort of quad strain. If it's going to be above the kneecap. If it's below the kneecap, you might start thinking some sort of patellar tendinopathy, or you might be thinking Osgood-Schlatter's, something along those lines, right? Generally speaking, these folks have more diffuse pain. It's somewhere behind the kneecap. One of the other giveaways to rule out other pathologies is usually pain-free passive range of motion, although in some folks you may see some pain at end range flexion. These folks typically hurt in weight bearing, but when you have them sitting, it doesn't hurt unless they sit for prolonged periods, right? That moviegoer sign. I also do a little palpation to the medial and lateral structures, so some joint line tests, maybe a few meniscus tests, make sure there's no swelling, and then pretty much surmise this seems more like patellofemoral. And also keep in mind the history. So if someone says they had a big, twist when they were running, cutting, changing direction, big pop, a lot of swelling, that's a sign there's probably some tibiofemoral stuff going on. They need to get that checked out. If this is more of a gradual onset, maybe it wasn't gradual, it happened kind of all at once, but they don't remember any popping, swelling, and the pain is kind of behind the kneecap somewhere, kind of diffuse pain. It seems a little bit more like patellofemoral pain. Anything to add there, Kevin?
Yeah, that's good. I think one of the other ones that you might see, especially if we're thinking about runners and runners' knee, is a distal femoral bone stress injury. So again, that might present a little bit differently. Perhaps the mechanism is consistent high mileage in a runner, or they're adding a bunch of intensity. And I think for this, you'd probably see a lot more pain weight bearing. So even just without loading the joint so much like you would in patellofemoral pain, I think like single leg hopping or double leg hopping would probably really, really jack them up. Where you'd think in patellofemoral pain, that wouldn't be the most provocative thing. I also think, I forget the sensitivity and specificity of this, the fulcrum test. I think it's not the best test, but it's something else we could throw in there as well. And then obviously when you just get a good history on their training and their diet, their nutrition, their sleep, it might give you a little bit of a lens into if they have a bone stress injury, if they had one in the past, maybe they're a little more susceptible to this. So that's another thing to just keep in mind. But I think like you had said, I think if you rule out the tendinopathies, which are different, they're going to have pain on the tendon. It's going to be pretty clear where their pain is. It's very localized, and they don't have swelling in the knee, so where it's not an intra-articular issue. Then we can be pretty confident narrowing down to a couple other diagnoses, and one of those would be patellofemoral pain. So hopefully ruling out those other things, and then thinking about the diagnoses of exclusion, thinking about the location of pain and what activities are bothering them that are loading the patellofemoral joint, then I think you can be pretty confident in that diagnosis. That's one of the most fun parts of being a PT, I'd say. Working through that stuff's a lot of fun. All right. So getting into a little bit about the clinical presentation and the subjective report from the patient. So again, just they're going to be complaining of pain around the kneecap or behind the kneecap that's worse with loading. So just keep those biomechanics in mind. Aggravating factors that you're going to hear them talk about are, again, activities that load the joint, perhaps that prolonged sitting. And then how frequently are they having these types of pain? So Collins and colleagues reported that 93.7% of patients reported pain with squatting who had patellofemoral pain. So, that's pretty staggeringly high. I think that's something when you're thinking of diagnoses you want to hear. 91.2% reported pain with stairs, 90.8% reported pain with running, and 81% reported pain with prolonged sitting. So, you're hearing these things, and I think you're feeling more and more confident this is what you're dealing with. Things that ease the pain in the patellofemoral joint, probably rest, right? When they're not weight bearing, when they're just hanging out, they're skipping leg day, they feel a little bit better. They're doing something like swimming rather than running, the knee feels a lot better. Again, making you understand this is a mechanical issue, and you're thinking, yeah, this sounds like patellofemoral pain.
Good stuff there, Kevin, as always. Yeah, one of the things that I mentioned previously, but we'll just double down on, is just that subjective history, right? We don't really have great special tests, spoiler, for this condition. It is that diagnosis of exclusion. So some of that subjective information is going to be very, very important. So make sure you're asking those questions, and you can start to tease out patellofemoral versus something else, right?
Okay, and then objectively, we've talked about these things, but when you go through your examination, you're going to want to palpate the patella. You're going to want to palpate kind of around the patella. You can do a little like medial glide and palpate underneath, so the backside of the patella, and then the medial femoral condyle, the medial plica, and you're going to see if they have pain in those areas. When you test strength, which is something I think you should do unless they're in so much pain that it's not worth it, and maybe you test a little bit down the road. But compared to healthy controls, patients with patellofemoral pain tend to have weaker quads measured by a handheld dynamometer. And, this is something that we have to be careful about, because do they have quad pain that led to the patellofemoral pain, or quad weakness that led to the patellofemoral pain, or do they have quad weakness because they've had pain for a while, and we know that pain inhibits strength. So something to keep in mind, but you can expect to see reduced strength on that side. This was only validated in a study that was looking at risk factors in military populations. And I believe that was looking at, is it causative of patellofemoral pain? So they found in this group of military recruits that when they had tested with weaker quads early on, those individuals had higher rates of patellofemoral pain. But again, that hasn't been replicated to my knowledge. I haven't seen that as a definitive risk factor. Quad inhibition is seen on surface EMG and may contribute to weakness. And that indicates there likely is some changes in the efferent motor output from the brain to recruit the quads. And that makes sense, right? Because we talked about that when you do contract your quads really, really strong, you may be increasing compressive forces on the patellofemoral joint, and it's probably the brain's way of trying to protect you from pain. And we did mention this a little bit earlier, but you might see decreased hip abductor and extensor strength. And then this was a quote from the clinical practice guidelines. There's a strong possibility that hip weakness is a result of patellofemoral pain and not a direct cause. So just make sure you're still separating those two in your head, but something clinically that we'll definitely be able to work on.
Yeah, it's and just to kind of double down on what we were talking about previously, and this is most of what I've seen as well in a multitude of studies, is that it doesn't appear that having hip weakness is going to be a risk factor for developing patellofemoral pain, but for some reason, folks with patellofemoral pain will present with decreased hip strength after the fact. There's even a couple studies, I think there's two that I've seen, that show that having a stronger hip was associated with patellofemoral pain, right? Now, we can kind of surmise maybe why that is. If you're moving more through your hip, you might be having more hip drop, more hip internal rotation. Maybe you're jumping, landing, running, and that's how you like to control forces. So essentially the hip is, you're choosing a hip strategy in order to do your activities. Does that lead to more lateralization of forces within the patellofemoral joint? I have no idea, right? We're just guessing at this point, but just want to say that it is not clear cut, right? So essentially these folks will probably have weakness afterwards, probably not beforehand. Does being strong present a problem? I don't know. You'll find that in a couple studies.
All right. And then clinically, if we go through a movement exam, people with patellofemoral pain they may walk, run, or negotiate stairs with reduced knee flexion compared to a healthy control. So you might see a little bit, they're less willing to load that patellofemoral joint. We also may see increased frontal plane movement during a single leg squat or step down tasks, and hop and landing are seen, hopping and landing. So they're jumping, they're landing, they may be landing with that stiffer knee on the aggravated side, and probably again to avoid loading the joint. So you want to look for these things when you're going through your movement exam. Are they demonstrating some of these strategies that they're trying not to absorb force in their knee so much? They're doing some of these tasks with a stiffer knee. And it's unlikely that these are causes of patellofemoral pain, but working on them, it may reduce pain, or it may help rehab as we work through the rehab process. So it's something we should address, but it's something that you might see on the exam. So you go through your subjective, you go through some of your objective tests, you're feeling more and more confident about this diagnosis, and then you see some of these strategies on a movement exam. I think just keep giving you confidence that you have the right diagnoses and things to address in rehab.
Kind of going back to the idea of correlation versus causation. One of my thoughts too that I like to tell folks is that if your knee hurts and you're trying to navigate any sort of knee intensive situation, more knee flexion increases stress in the patellofemoral joint when you're loaded up, right? So what are some strategies you can do to reduce some of the knee flexion? Well, you can go into valgus. You can drop that hip, right? You can shoot the hip back. So you see these aberrant motions after folks have patellofemoral pain. And a lot of folks say, oh, that's the reason why you move poorly. That's why you have pain. And that could be part of the reason why you ended up in pain, right? I'm not trying to say it's not, but the other no-brainer is like, dude, if your knee is killing, of course you're going to move differently, right? So just keep that in mind. You see this quite a bit. And then in terms of what to do from a treatment perspective, we'll talk about that in a future episode.
All right. I think, Dan, this is your favorite part of patellofemoral pain, right? Kinesiophobia.
Yeah.
You want to touch this slide?
Kinesiophobia. Yeah. So I snuck this slide into Kevin's presentation just because I did want to know a little bit on psychosocial issues surrounding patellofemoral pain. And it's always interesting to me because I think these psychosocial issues are probably going to be in most conditions. It's just that we only start to find this out when we start to study them. So you won't find research into psychosocial issues in certain pathologies, but it doesn't mean it doesn't exist. But we're finding these in patellofemoral pain as well. This is a study by Hott et al. In 2022. Basically, patients with patellofemoral pain had elevated levels of kinesiophobia, which, depending on the study you look at, is going to correlate with pain levels, right? And this makes sense. If your knee is killing you, you're not going to want to load it very much, right? So maybe this isn't rocket science, but those folks also tend to have more emotional distress. Again, if your knee is killing you, maybe that's making you stressed out. They also have higher rates of widespread pain, which is an interesting one. I'm not sure if that's due to the stress, kinesiophobia, or we're just seeing that maybe patellofemoral pain is going to be related to folks that are more sensitive, potentially. Not really sure what that means, just kind of brainstorming. And this was compared to the general population or pain-free controls. The other piece, which I thought was good and something maybe we can try to push, is that folks with patellofemoral pain that had higher self-efficacy, that was associated with better function, health-related quality of life. So we'll talk about this in the next podcast episode, but essentially we want to educate these folks and maybe use a few treatments that reduce kinesiophobia and kind of promote that self-efficacy, right? Because maybe we can push these people into a better place, improve their outcomes if we address these things. So any thoughts on that, Kevin?
Yeah, I think that's a good point that kind of made me chuckle a little bit when you said that this exists in other conditions. It's just that if it doesn't, it's just because it hasn't been researched yet. So I thought for the longest time that only back pain and neck pain were associated with kind of those psychosocial issues, because those are the ones you hear about all the time. But yeah, obviously it relates to many, many things, right? And people don't know. They don't know that, does this mean I'm going to get arthritis if I have this type of pain? Am I going to need a knee replacement? And, those are things you want to talk to your patient about and reassure them that there's things we can do for this, because I think a lot of times, especially now, you just Google everything and you Google knee pain and it says you need your knee amputated immediately. and they're going to be fearful of that. So yeah, that's a good point. I think we got to think about that with every pathology we treat.
Yeah, no, I don't want to get too far off topic, but that's a huge problem for consumers. We always talk about with nutrition because there's like crazy amount of terrible nutrition advice out there. So much so that like it is very hard as a consumer to figure out what's okay and what's not. I think that's, presents similarly with pain problems, right? And we think nutrition is a huge issue that everyone needs to know about, right? And obviously it is. But then if you look at some of these stats, like low back pain is going to be the second most common issue that patients present to a primary care physician with, and then knee pain is right down the line there. So it's like in the top 5, top 10. This is a global problem that people are facing throughout the course of their lives. And I think the available evidence we have, or like information that the average patient has access to, is not always the best. And that's a big problem. So, it stinks, but obviously we're out there trying to push evidence-based care. Hopefully it catches on. My YouTube channel is far less popular than other folks that don't have a similar approach. So take it for what you will, but that's kind of how things are currently. So
yeah, last thing I'll say on this, and then I had sent you, like, obviously won't name them, but someone random's Instagram where they had 200,000 followers almost, and they're just, everything we're saying right now about patellofemoral pain, like it may or may not be correlated with excessive foot pronation or with increased Q angle. And this page just has like, you're dealing with knee pain because you're pronating too much, and like here are exercises to work on your foot supination. It's like, oh, so yeah, you're right. Consumers, this is the type of information they're often consuming, and then they're fearful of pronating their foot because they're developing kinesiophobia around that because they think it's gonna make their knee pain worse. And yeah, you got to keep
and they come in
fighting
to
that
see
big
you.
fight. Yeah.
And they're like, Q angle's off my foot. Look, it's so flat. We got to address that, so on and so forth. And yeah, maybe, but like the thoughts make it a little prohibitive to have success because they get so wound up in these beliefs, and then you're trying to push them in the right direction without turning them away because they see that your information is against what they've learned and they don't like that, right? And that's hard. If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms, or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks, because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is, if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place, so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you, and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the fitness pain-free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now.
So back to patellofemoral pain. Does patellofemoral pain recur? If you have this once, are you going to have it again? Unfortunately, probably. So the research shows that recurrence rates can be as high as 70 to 90%. And while traditionally viewed as self-limiting, I think this gives us some hope. Increasing research data suggests that patellofemoral pain is often recalcitrant and can persist for many years and may cause a decline in sports participation. So the reason why I said this is hopeful is because it's not self-limiting. We're not just going to wait and see if this goes away. This is one of those conditions that if we see a physical therapist for, hopefully we can help prevent this recurrence and help get people better. And then one study by Langhorst et al. Derived long-term follow-up data from 2 randomized controlled trials, and this was an N of 310, pretty good. The pain severity with the VAS score and function with the anterior knee pain scale were measured between 5 and 8 years after the onset of patellofemoral pain. And just for looking at recurrence, they had 60 of these patients completed a follow-up questionnaire. And then 34, so 57% of them reported an unfavorable recovery from patellofemoral pain 5 to 8 years later. So, in this 60 patient group, a little more than half, 5 to 8 years after their diagnosis of patellofemoral pain, still weren't happy with how they were doing. Multivariate models revealed that baseline patellofemoral pain duration, so if you have patellofemoral pain for longer than 12 months and lower self-reported function, they were predictors of a poor prognosis. So I think you see this with a bunch of other conditions, but if you have someone that comes in with patellofemoral pain who's had it for a year and a half, that's someone who might not do as well. Obviously, that's not always the case. I think if they get high quality care and there's things they haven't tried before that you can help them with, hopefully their prognosis is a little bit better. But just keep in mind that this does recur at high rates, and it is common to have pain years and years later. But hopefully, again, we can help these folks avoid that.
Yeah, these are crazy stats. And I think this is always like my answer to the revert to the mean police, right? Like, it doesn't matter what you do, they're going to revert to the mean, right? And what's funny is, so patellofemoral pain making up 25% of all, orthopedic cases we see worldwide. Low back pain's even more common, has a terrible recurrence rate. And then rotator cuff related pain, which is going to be the most common shoulder pathology and is equally up there in terms of how often it presents. They don't have a good natural history, right? So at least in my mind, are there a few things that do kind of revert to the mean? Well, sure, of course. But these big ones, generally not. They don't have a great long-term outcome. So if you do exercise them, they do tend to do a lot better. And even when we do exercise them, we have a hard time getting this to go away. So I just do think that we need to be as good as possible as physical therapists. This is certainly something you shouldn't feel bad about treating. And if you just let it go, and we'll talk about treatments later, wait and see, it does badly, right? It doesn't do great if you just kind of let this go over the course of time. So I would say that you definitely do want to try to treat this one. You don't want to let it go over the course of time, and you're doing your patient a disservice.
All right, and then just a little bit more on recurrence, because some of these statistics are crazy. So Blonde and Hansen, they looked at 250 athletes from a sports clinic. There were 122 females and 128 males with an average age of 21 years old. And they were instructed to complete a program to strengthen their VMO. 5.7 years after, there was a follow-up questionnaire that was 5.7 years later on average. Only 27% of these folks were pain-free. So 73% still had pain. And then of that 73% that still had pain, 52% had pain, but it was decreased. 35% were unchanged, and 13% had an increase in pain. Affected athletic activity in 74% of cases, and it affected employment in 6% of cases. So, definitely something that we can help intervene on. You know, these statistics are a little bit discouraging, but I also don't know if strengthening the VMO is the only key to success. So, you know, maybe this study is almost a revert to the mean. I mean, who knows? But you know, I think that is yeah, again, so 73% still had pain. So higher than the previous study, but you know, take it with a grain of salt with the treatment approach, but recurrence is still very high. So hopefully we can improve that a little bit with our treatments.
Yeah, I just want to kind of like reiterate what Kevin said. 6 year follow up is pretty long term, right? And we're finding that 3/4 of those folks still have pain. So, this is kind of recalcitrant situation that's or condition that's really hard to treat. Folks are having very long term pain, so it's not reverting to the mean. And also speaks towards maybe we need to be better about our rehab strategies. We'll talk about that in a future podcast, but just VMO strengthening by its own, who knows, right? It is quad strengthening. So, we know that can be effective, but can we be more effective? Probably, right? And we'll talk about that in future episodes.
All right. So then just a little bit of conclusion slide. 'Cause I know we went through a lot. So patellofemoral pain occurs as anterior knee pain that may or may not be painful to palpate around or behind the kneecap. And it does increase with increasing knee flexion loads. Secondary to there being more joint contact surfaces and more quad contraction. So as you get more and more joint contact, if those joints are a little bit irritated, you're going to get some pain. And then as the quad contracts and it's compressing on the joint and it's really creating a lot of torque, could also create more knee pain. And then this is just a quote, again, I believe from the CPGs here. So the most frequently cited predictors of poor outcomes are that longer duration of symptoms before intervention, overall lower function, and worse pain. Kind of makes sense. Negative psychological stress and altered pain sensitization were present in patients with patellofemoral pain, as Dan talked about. And for the majority of patients, the educate and wait approach of avoiding pain provoking activities is not effective in improving pain and function in the short, medium, or long term. So, as we had said, not a wait and see approach, but something that we want to be proactive about treating. So, yeah, a little bit of a summary there.
And then I'm just reiterating the same thing you said, but one of the things that pops up in my mind is that longer duration of symptoms prior to seeing someone, maybe earlier intervention is going to be a little bit better for these folks, right? Maybe we need to get them through the door a little more quickly. I think when folks think about patellofemoral pain, it's not a dangerous situation, but if you let it go for long enough, 6 years later, you might end up being in pain. Maybe we should make this a little bit more important in our eyes and our patient's eyes, and just let them know. I'm not trying to scare any patient, but typically patellofemoral pain is not something you're eventually going to need surgery for unless it develops into arthritis years and years later, but it can be debilitating for long periods of time. So I think that getting them into PT as quick as you can, right? And then doing a great job with your education, trying to give them hope, trying to address any of those psychological risk factors, and just kind of promoting them, pushing forward, trying to affirm their positive actions, right? So making sure they're staying active, not being fearful of movements. But the other part is they can't blow through a ton of pain. And, we're going to talk about this in the future. So, all right. So now you have some good background on patellofemoral pain, but it doesn't help you very much because you have a patient that's in front of you. Their knees are absolutely killing them, right? And they want to find some good exercises for that knee pain. Well, whoa, over Kevin's head, something just popped up. Oh, where is it? Nope, not over there. Oh, all the way over here. And in this link is a video on my favorite exercises for patients with very painful knees. So go ahead and click on that link and I'll see you there. If you're watching this on YouTube, please, please, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain Free Insiders. So Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. and I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course, and one of the big things I add to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course, Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.